So I'll be talking to you on the long-term complications of hemodialysis. So this presentation is on the based on a case-based format. So we will be discussing about 8 or 9 patients who had some sort of a long-term complication on while they were on hemodialysis. So we will come to the first patient. Now the first patient is a patient with the uremic symptoms on maintenance dialysis, which is rather unusual since the patient that was on maintenance hemodialysis, he should not have been getting these uremic symptoms. So I'll go to the case. So this is a Mr. X, a 70-year-old male with a history of chronic glomerulonephritis and hypertension with chronic kidney disease on thrice bicarbonate dialysis. The axis was left radiocephalic fistula, and there was a good flow in the arteriovenous fistula. And he presents to the dialysis unit with complaints of tiredness, nausea, and easy fatigability. And on evaluation, the hemoglobin was 9.5. There was a normocytic anemia, but there was mild hyperphosphatemia, and vitamin D, calcium, PTH were all in the normal range. The liver enzymes were normal. So he underwent a systemic evaluation which showed a normal abdomen, chest, central nervous system, and a cardiovascular system. So the even after ruling out any other systemic illness or localized process for his complaints, and a question was raised whether the adequacy of the thrice weekly dialysis, which was reported as 0.9, and the urea reduction ratio was detected to be around 45%, which is far low than was prescribed. But the patient usually tended to stop the dialysis by about 3 hours. And he used to give multiple excuses like the need to attend a social function. He had some personal matters to attend to and some family issues. And going through the prescription, it was noted that 18 kg needles were used for cannulation in spite of having a good vascular access on request from the patient. So the patient was comfortable with using an 18 kg needle. 50 ml per minute was usually given to the patient, and the starting blood flow was kept till the end of the dialysis. So this was what was happening to the patient. So these are the signs and symptoms of patients with the chronic kidney disease due to advanced renal failure. That is some features of uremic symptoms like fatigue, lethargy, there will be cognitive dysfunctions. The essence of making a diagnosis is by looking at the KT over V. Now, the KT over V, what is it? So KT over V is derived from a mathematical and for a patient on a thrice weekly maintenance hemodialysis, if you want to say whether the KT over V is adequate or not, you should maintain a value of about 1 urea by the dialyzer. It is influenced by the dialysis surface area, effective blood flow, ultrafiltration, and recirculation, as well as the dialysis fluid flow rate. Treatment. Now, the volume of distribution of the urea is influenced by the patient's weight, height, age, and sex of the patient. So these are the various factors which determine KT over V. Now, how is it related to the urea reduction ratio? You need not worry about this graphs. Just remember that it is the inverse logarithm of 1 minus. So I was discussing about KT over V. So the KT over V is low. Then think about what the remedial measures that has to be done. One is to increase dialysis surface area. Second thing is to increase the blood flow rate. You have to increase the dialysis flow rate. Ask the patient to spend more time on dialysis, and you have to rule out vascular access problems. So this is what should be done. And now the gauge of the needle that is being used for dialysis. So if you use as you see from this cartoon, If the gauge of the needle, the numbers go up, the inner diameter decreases, the blood flow rate also decreases. So preferably try to use at least a 15 or a 16 gauge dialysis needle for all the patients with a good vascular access. So the remedial measures that were done in these patients included. So the blood flow rate was increased to 300 ml per minute. The cannulation needle size was changed to 15 gauge. The patient was counseled to spend about 4 hours on maintenance dialysis, and the dialysis surface area of the selected dialyzer was ensured to be proportional to the body surface area of the patient. So the message to the dialysis technician or the dialysis nurses is you have to inform the nephrologist about patients who are not doing well on maintenance hemodialysis. You have to maintain the blood flow rate at least 250 to 300 ml per minute. Use a 15 or 16 gauge needle and stick to the treatment time and periodically assess a vascular access. So these are the things that is to be done. Now case 2. Case 2 is a malnourished patient who presents to the treating unit with complaints of certain complaints. So this patient is Mrs. D, a 49-year-old female, a diabetic kidney disease on thrice weekly maintenance dialysis, reports to the nephrology clinic with complaints of tiredness, fatigability, and lethargy. The weight is recorded as 45 kgs, the height is 167, and the body mass index is only 16. Labs showed a hemoglobin of 9.6, normocytic anemia. KT over V was 1.3. Liver enzymes were normal except for hypoalbuminemia. Serum albumin was 2.8. Normal thyroid function, normal mineral and bone metabolic parameters. And systemic examination was normal except for CKD features. So as it is obvious from the results, the patient has got malnutrition. So the malnutrition could be don't be alarmed by the big slide. It only shows that the patient on dialysis can have malnutrition, and the causes of malnutrition could be a dialysis-induced iatrogenic cause, that you are creating malnutrition in these patients by your treatment process of dialysis, or it can be a non-iatrogenic cause of malnutrition. Now, among the dialysis related issues, you can have problems with the dialysis access. So if you have got a persistent inflammation in the dialysis access, it can lead to endotoxin levels, which can continuously trigger inflammation. Decreased dialysis adequacy can lead to metabolic acidosis. Dialyzer membrane, if the dialyzer membrane is not good, there will be decreased removal of uremic solutes. There will be nutrient loss. If you are reusing the dialyzer quite frequently, again, you can have nutrient loss. And ultimately, this leads to inflammation, metabolic acidosis, uremia, and proteolysis of the muscles, and ultimately it will lead to malnutrition. Then there are certain non-iatrogenic causes as well, like psychosocial factors like depression, stress, poor social support, financial constraints, low diet quality, and high diet monotony. All these again can lead to non-iatrogenic causes of malnutrition. And ultimately, all this can lead to malnutrition. And one of the things is that this malnutrition and atherosclerosis are closely linked. So again, don't be terrified by this slide. It just shows the link between malnutrition, atherosclerosis, and vascular calcification. So traditionally, we thought that the traditional risk factors like age, gender, diabetes, hypertension all led to atherosclerosis. But in a patient who is on dialysis, you have got novel risk factors like malnutrition itself can cause atherosclerosis and vascular calcification that leads to an adverse cardiovascular event in these patients. So what is the effect of all this malnutrition which happens in these dialysis patients? So long-term dialysis and malnutrition is associated with frailty. So the patient becomes frail and they are liable to fractures. They can have an adverse cardiovascular event. It can lead to hospitalization in these patients, and it can lead to increased mortality in these patients. So how do you assess malnutrition in these patients? So the classical way of assessing malnutrition is to do what is known as a subjective global assessment form, which is a questionnaire, and you calculate the final points that you get by doing this subjective global assessment, and you rate the malnutrition based on the overall subjective global assessment form. Now, the muscle mass wasting, you have to take it very seriously if the patient complains of muscle mass wasting. So if there is muscle mass wasting or more than 5% over 3 months or 10% over 6 months, then it could be an indicator of malnutrition. Of course, there are other parameters like albumin, cholesterol, pre-albumin, all these other factors are also there. So what is a step that you do? So this is a recommendation. So the patient has got chronic kidney disease stage 5 and is on maintenance dialysis. Always a first route of nutrition supplementation is oral. So you give oral supplementation and try to increase muscle mass. You have to look at the biochemical parameters also, like serum albumin, pre-albumin, all these things have to be looked. Then if the patient is still not gaining weight, then you'll have to alter the dialysis prescription so that the adequacy of the dialysis is adequate. Then you have to think about tube feeding or parenteral feeding. And probably you can start with appetite stimulants and other therapeutic measures. So the message to the dialysis nurse or the technician is that you have to inform the nephrologist about the patients who are losing weight and are not doing well on maintenance dialysis, and to measure the pre-dialysis and post-dialysis weight diligently. So the measurement of the weight should be very carefully done, and it should be recorded for all patients, pre-dialysis and post-dialysis. And you have to involve the renal dietitian in the management of dialysis patients. Of course, you have to take a dietary history, and a dietary counseling has to be given to these patients. Now coming to the case 3. Case 3 is a patient with a prolonged bleeding from an arteriovenous fistula after hemodialysis. So the case scenario runs something like this. So this patient is Mr. Y, a 78-year-old male with diabetes and on twice weekly maintenance dialysis. He reports to the dialysis clinic with complaints of excessive oozing from the arteriovenous fistula, which persists about 8 hours after hemodialysis. So it's been going on oozing from the fistula till about 8 hours till he presents to the emergency. So the dialysis nurse reports that his blood flow is 250, but has a venous pressure of about 170 millimeters. And his antiplatelet ducts have been on hold since 4 weeks because of this complaint. And the lab parameter shows hemoglobin of 11, normal platelet count and coagulation parameters, and a normal liver function. So the fistula was examined. It showed a thrill. The pulse augmentation was negative, and the arteriovenous fistula becomes prominent or it doesn't collapse on arm raising. So this is a background of the patient. So this patient on further evaluation was found to have an outflow stenosis. So this is arteriovenous fistula, and the fistula as shown in the fistulogram has got an outflow stenosis. So the classical features of an outflow stenosis will be the patient had a prolonged bleeding after fistula removal. The flow of the fistula was can be low. The high venous pressures will be recorded on dialysis. The fistula doesn't collapse on arm elevation. Then there are other features with regards to palpation and auscultation. So this is a diagram of an arteriovenous fistula where you see an inflow artery. From the inflow artery, the fistula, this is a arteriovenous fistula. This is a venous segment, and this is arterial segment. So this is a site of the anastomosis. So the inflow stenosis usually happens somewhere here. This is a juxta-anastomotic. Juxta-anastomotic means approximately around 2 centimeters from the site of anastomosis. And this is outflow stenosis. Outflow stenosis purely happens in the venous segment where you get a narrowing of the venous segment. So this is a inflow stenosis, and this is outflow stenosis. So the outflow stenosis, the arm doesn't collapse on elevating, the fistula doesn't collapse on arm elevation. So if you got a forearm fistula, so this is a radial fistula. The one of the most common sites will be inflow stenosis, where around 49% will have inflow stenosis, whereas venous outflow stenosis roughly can happen at the close to the proximity of the inflow or away from the inflow. Whereas in an upper arm arteriovenous fistula, like a brachial fistula, the majority of the venous outflow obstruction happens proximally, happens in the proximal segment. So what will be the complications of an arteriovenous fistula? So the problem with an arteriovenous fistula is that it can have accessory circulation and inadequate dialysis, and it predisposes to thrombosis. And because of the increased venous pressures, there will be prolonged bleeding from the arteriovenous cannulation site. So what should be done for these patients? So the guideline is based on the KDOQI guideline. How do you treat stenosis? So the stenosis should be treated if there are abnormal clinical or physiological features along with anatomical abnormality, like if there is more than 50% stenosis, along with the decreased access blood flow, elevated venous pressure, decreased dialysis dose, or abnormal physical examination. So this is a stenosis. And what do you do for treatment of this is by doing a fistuloplasty. So a balloon angioplasty is done, and the fistula, the stenotic segment is dilated. So the importance to the dialysis nurse or the technician is you have to assess the vascular access regularly and inform the nephrologist in case of a poor inflow through the fistula, prolonged bleeding after removal of the needles, or poor adequacy of dialysis. So these are the things that are important. Now coming to case 4. Case 4 is a dialysis patient with complaints of swelling of the face and neck. So Mr. W, a 65-year-old male with the background history of chronic glomerular nephritis, hypertension and chronic kidney disease on twice weekly maintenance dialysis. So the axis is a left brachiocephalic arteriovenous fistula, and he presents to the dialysis clinic with complaints of facial, neck, and left arm swelling since about 1 month. He gives history of multiple failed arteriovenous fistulas and has undergone multiple vascular access cannulations. There is no history of thyroid disease and no pedal edema. So this is a picture of the patient. So as you see, there is swelling of the left arm. There are dilated veins, and he has got an arteriovenous fistula here. So this could be another way by which the patient can be presenting. So as you see, there is gross upper facial as well as neck edema, and there is an perm cath also here. So this is what happens here. There is a narrowing of the brachiocephalic vein. So the veins from the the face as well as the neck as well as around the brain drains into this subclavian and the jugular veins. And because of the stenosis, there will be increased venous pressure, and this manifests as edema. So the points of block happens within the right brachiocephalic vein, or it can happen in the subclavian vein and left brachiocephalic vein. These are all sites of narrowing or stenosis or thrombosis. So this is a venogram of this patient, and the venogram of the patient shows this is a venogram which shows a narrowed segment, and this is a venogram which is done after successful opening of the stenotic segment. So the causes of such an obstruction can be stenosis, or it could be a thrombus. So stenosis, as we discussed in the previous case scenario, what do you do in stenosis is you do a fistuloplasty or a venoplasty. Whereas in the case of thrombus, you can do a thrombectomy. It can be a catheter aspiration thrombectomy where you put in the catheter at the site of the thrombus and you aspirate out the thrombus. So the blood clot is removed by suction, or you can use a mechanical thrombectomy. Here the blood clot is broken up into small pieces and then it is removed. So these are all interventional radiology procedures. So the message to the dialysis nurse or the technician is that so upper arm facial or neck swelling often represents central venous obstruction, and it can be due to stenosis or thrombosis, and you have to inform the nephrologist about these patients, and these patients should be asked to meet the treating doctor. Now coming to case 5. Case 5 is a patient with the bulging arteriovenous fistula. So this patient is a 60-year-old male on thrice weekly maintenance dialysis and presents to the dialysis clinic with complaints of a bulging left brachiocephalic arteriovenous fistula. He is otherwise healthy with the normal clinical and lab parameters. So this is a picture of such a patient with a bulging forearm arteriovenous fistula. So this obviously is an aneurysm. So I'll take you through the anatomy of a blood vessel. So the blood vessel has got 3 layers. The innermost layer is known as the intima. Then you have the media, and then the adventitia. Now the aneurysms can be of 2 types. One is a true aneurysm, other is a pseudo aneurysm. In a true aneurysm, what happens is that all the 3 layers of the vessel wall will be part of the aneurysm. Whereas in a pseudo aneurysm, only the adventitia will be the part of the aneurysm. This is a pseudo aneurysm. There is a true aneurysm. And what is the problem with this aneurysm? The problem with this aneurysm is that because of the stretching of the skin overlying the aneurysm, the skin becomes friable and it can become easily infected. And the friable skin can lead to an increased risk of arteriovenous fistula site infection also. So this is a really bad arteriovenous aneurysm, which has got multiple punctate points, and this is looks like a fistula that is about to rupture. So an appearance of a fistula, you compare this fistula site with a normal looking arteriovenous fistula, you see how bad this arteriovenous fistula is. So these patients, these are something like taking time bombs. The fistula can rupture at any point and you can get a torrential bleed. and this often can lead to life-threatening problems because of this massive bleeding that can happen from the arteriovenous fistula. So these are the indications for repair of the arteriovenous fistula, where the skin is overlying the fistula is ischemic or compromised, when there is a high risk of fistula rupture or available puncture sites are limited. Now, the indications for revision of a pseudoaneurysm, again, the indications are almost the same. Whereas in the case of a graft, if the pseudoaneurysm is enlarging in size or exceeds twice the diameter of the graft, then it is an indication that the uh, fistula should be repaired. And any cannulation through a pseudoaneurysm must be avoided. So, in order to prevent this, you should be familiar with the two proper cannulation techniques. One is a rope ladder type of technique, and the other is a buttonhole technique. So the buttonhole technique is used when there is a cannulation segment is very short and there is a significant cannulation induced pain, or if there is a difficulty in cannulating the fistula. And the rope ladder technique is used when there is a long segment that can be cannulated, when there is no needle phobia, and in the case to prevent an aneurysm. And how do we put the needle? So the putting the needle is in antegrade or retrograde. You have to bevel up and then rotate 180 degrees to prevent the back wall or posterior wall infiltration. And you should use about 20 to 35-degree angle. Now, what is this buttonhole cannulation? So the buttonhole cannulation, the procedure involves disinfection of the arm, scab removal followed by needle insertion. Initially, use a sharp needle puncture at the same insertion angle by an experienced cannulator. So the same site is used and a sharp needle puncture is used initially. And the aim of the technique is to trigger enough fibrosis so that the sensitivity of the patient to the needle pain will be decreased. Later, you can use blunt needles are used, and the same track is used for cannulation. And this is used when there is only a short segment for cannulation. So this is a buttonhole cannulation. Now, the rope ladder technique is the one that should be used if I got a long segment that can be used for cannulation. So this technique goes something like this. So if this is an arterial needle, this is a venous needle, venous side segment. So you put the arterial needle here and put the venous needle here. Then you have to change the needle regularly. So the next dialysis, when the patient comes, you have to predetermine you go 0.5 centimeter or 1 centimeter above. You put the arterial needle here, and the venous needle is also put about 1 centimeter above. So the needle cannulation site is changed continuously. This is a rope ladder technique. So this is the most recommended technique for cannulation, and this prevents infection, stenosis, aneurysm, and extends the lifespan of the fistula. So the proper cannulation technique is a mandatory for all dialysis personnel. So the message to the dialysis nurse or a technician alert is you have to use a proper cannulation technique. You have to recognize impending arteriovenous fistula rupture and take appropriate action. Now, case 6 is a patient who complains of severe pain in the hand during dialysis. So this patient is a 76-year-old male, a long-standing diabetic with history of peripheral vascular disease, was started on regular maintenance dialysis through a left radiocephalic AV fistula about 6 months back. Now the patient complains of severe pain in the hand during dialysis. So this is important. So the patient complains of severe pain in the hand during dialysis, which improves on stoppage of the dialysis. And on examination of the patient's hand, you notice that there is a poor pulsation of the ulnar artery on the left side, and there are digital ischemic ulcers. So the patient's hand looked something like this. Here you can see there is a fistula. There is a ischemic ulcers on the hand of this patient. So this condition is known as dialysis-associated steal syndrome or DAS. So in what happens in a patient who is undergoing dialysis is that this is a arteriovenous fistula, this is a vein, this is an artery. So the flow through the vascular axis is about 600 ml per minute, and the blood flow is about 300 ml per minute. So the blood is taken from the arteriovenous fistula and it goes into the dialysis. So if the artery is normal, it should it should be supplying it should be supplying the distal part of the hand, and the blood flow to the distal part of the hand will be intact, and the arterial flow goes something like this. Now, if there is a problem with this arterial segment distal to the fistula, what will happen is that the entire arterial flow will be stolen by the arteriovenous fistula, and the whole blood will be diverted into the vascular axis. So the arteriovenous fistula actually steals blood from the AV fistula. So when the blood is stolen from the artery, the distal perfusion is impaired, and you will get a impaired flow to the vascular bed distal to the arteriovenous fistula. So that is why there is digital ischemia. There will be ischemia to the blood flow to the distal part of the limb. So what do you do to address this problem? Often you require a surgical correction. And the most common surgical technique that is employed is known as drill procedure. This drill procedure is known as distal revascularization and interval ligation. So this is arteriovenous fistula. You ligate the fistula just distal to the site of anastomosis, and you put another PTFE graft which supplies the blood from the artery to the distal part of the arm. So this is what is done to treat the dialysis associated Steele syndrome. Now, the message to the dialysis nurse or a technician is that you should never ignore the symptoms that the patient tells you while on dialysis, especially with regards to the vascular access, and ask these patients to report to the doctor. So it could be a part of dialysis associated Steele syndrome. Now, case 7. So this is a patient with elevated liver enzymes on maintenance dialysis. So this 70-year-old lady with a background history of chronic glomerulonephritis, systemic hypertension, and twice weekly maintenance dialysis was noticed to have elevated liver enzymes on routine monthly lab tests. And she was not on any erythropoietin, was needed to transfuse about blood transfusion, and her hemoglobin decreased to less than 7 grams. So because of financial constraints and other social factors, she was not on any tablets or on erythropoietin. And going through the history, it revealed that she had about 12 blood transfusions in the past 6 to 7 months. And on examination, the patient was pale. There was no jaundice, no hepatosplenomegaly. The liver enzymes STPT was reported to be 74 and SGOT around 89. Last month's report was around 7 and 10 of STPT and SGOT, normal bilirubin, normal alkaline phosphatase, normal serum albumin, no albumin globulin reversal. Now, what should be the next course of action? So the value of the transaminases in patients on maintenance hemodialysis is often single-digit values. Why? Because there will be dialysis, there will be associated B12 or the B complex vitamin loss. So the transaminase levels often would be something less than 10. And any raise value should be considered abnormal. And always rule out viral hepatitis B and B as well as hepatitis C by doing an ELISA and PCR. And the message to the dialysis technician is you have to reuse these dialysis separately, or you can use a single-use dialyzer if the patient is well off. You have to disinfect the machines methodically. Universal precaution should be applied, and you have to check the vaccination status of the patient, maintain a proper and updated medication chart of this patient. And of course, these patients have to be sent to the nephrologist for further evaluation. So there'll be a review of the medication chart, order tests, and gastroenterology referral because of this abnormal liver functions. And the maintaining a proper and updated medication chart is important. Why? Because there will be a lot of medications which can alter the liver enzymes of these patients. So the patient might have been put on an antitubercular drug, ATT, which can alter the liver enzymes. So it is a duty of the dialysis nurse to update the medication chart of these patients in a quite regular fashion, so that nothing is missed out. Now, coming to case 8, these are patients with very, very long-term complications of dialysis. So a patient with increasing hemoglobin on maintenance hemodialysis. So this 75-year-old lady with a history of chronic glomerulonephritis, hypertension on twice weekly maintenance dialysis was referred to the dialysis clinic with increasing hemoglobin levels. So the dialysis vintage was around 14 years. Well, so this patient was on dialysis for about 14 years. And erythropoietin was stopped 2 months back when her hemoglobin was reported to be around 14.5. And on examination, the vitals were okay. Systems were normal, no hepatosplenomegaly. There was a left radial arteriovenous fistula with a good thrill. And the lab showed a hemoglobin of around 15.2 gram per deciliter. So basically, the diagnosis is something which is known as acquired renal cystic disease. So this is a CT of this patient. So this is an AT kidney of the patient where you can see multiple cysts in these patients. So cystic lesions are seen in these patients. So this complication usually happens around 8 to 10 years post dialysis when these patients start developing the cyst in their native kidneys. And this cyst will start stimulating the erythropoiesis, and the hemoglobin level will go up. And what is the most important trouble in these patients is that these cysts are considered to be pre-malignant, especially if there are more than 3 centimeters in size. So you have to be aware and vigilant of when about this cysts. So what do you do when these patients develop such cysts? So this is in these patients can lead to problems like gross hematuria, lumbar pain, fever, erythrocytosis, and symptomatic. It can be symptomatic, and often the diagnostic investigation will be a contrast enhanced CT scan or an MRI. And if the size of the tumor is more than 3, you have to do a nephrectomy. And if it is less than 3 centimeters, you with complications like bleeding, again you will have to consider unilateral nephrectomy. Why nephrectomy is done in this patient is that it is a pre-malignant condition. So the message to the dialysis nurse or the technician is that think about this condition in patients with a long-term dialysis vintage with a presence with increasing hemoglobin, hematuria, lumbar pain, or increasing vascular access thrombosis. So this patient, these symptoms should be taken seriously and should be evaluated. Now, the last case is a hemodialysis patient with complaints of shoulder pain. So this 71-year-old lady on thrice weekly maintenance dialysis since about 18 years presents to the dialysis clinic with complaints of bilateral shoulder joint pain. So on examination, there is painful restriction of all joint movements of the shoulder joints bilaterally. And on subsequent evaluation, she was also noticed to have a bilateral carpal tunnel syndrome. So these are the X-rays of the patient, and the X-rays of the patient reveals numerous cysts, which is seen in the humerus, as well as cysts within the radial bones. So this condition is known as beta-2 microglobulin amyloidosis. So this is beta-2 microglobulin is a protein which is found in the patient's blood, and it is normally excreted by the kidney, but it is not removed well by hemodialysis or by the dialysis filter. So long-term accumulation of beta-2 microglobulin happens in these patients, especially if the dialysis vintage is more than 12 to 15 years. And these generally presents with a wide range of features like carpal tunnel syndrome, joint pain or stiffness, then fractures, then it can even lead to paraplegia, and the visceral manifestations are often rare. So the clinical features usually will be something like a carpal tunnel syndrome, periarthritis, flexor tenosynovitis, bone cysts, as well as districtis spondyloarthropathy. Now, how do you make a diagnosis? By radio imaging, like CT scan, then MRI scan, ultrasound, and the gold standard is the biopsy. Now, there is no specific treatment for these patients like dialysis, hemodialysis. You can people have tried out highly biocompatible high flux membranes. Then some people have advised peritoneal dialysis, but there is no sufficient data. But however, the definitive treatment is renal transplant. So thank you for listening to me.